Hello and welcome to Doc AT. In today's video, we're diving into the critical topic of cardiogenic shock. What it is, why it happens, its pathophysiology, causes, symptoms, diagnosis, and treatment. Let's break it down together. Don't forget to like, share, and subscribe for more amazing content. Cardiogenic shock is a life-threatening condition that occurs when the heart cannot pump enough blood to meet the body's needs, resulting in inadequate tissue perfusion and oxygen delivery. Common triggers: myocardial infarction, heart attack, heart failure, cardiomyopathies, arrhythmias, myocarditis, valve dysfunction, cardiac tamponade, pulmonary embolism, pathophysiology, failure of the heart to pump effectively, leading to reduced cardiac output, despite adequate blood volume, and poor perfusion of tissues. Often involves left ventricular dysfunction, but right heart failure or valve abnormalities can also contribute. Increased ventricular filling pressures leads to pulmonary congestion. Compensatory mechanisms: peripheral vasoconstriction increases systemic vascular resistance. Increased heart rate to compensate for low stroke volume. Activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system to maintain blood pressure. These responses worsen myocardial oxygen demand, creating a vicious cycle of ischemia. Cellular consequences: tissue hypoxia leading to anaerobic metabolism, acidosis, and organ dysfunction. Causes: ischemic, acute myocardial infarction, most common cause accounting for 80% of cases, usually associated with extensive damage to the left ventricle. Mechanical, ventricular septal rupture, mitral valve regurgitation, free wall rupture, aortic stenosis, or other critical valve abnormalities. Other: cardiomyopathies, dilated or hypertrophic cardiomyopathy leading to decreased cardiac output. Myocarditis, inflammatory damage to the myocardium. Arrhythmias, atrial fibrillation, ventricular tachycardia, bradyarrhythmias impairing cardiac output. Cardiac tamponade, fluid accumulation in the pericardium compressing the heart. Pulmonary embolism, massive embolism causing right ventricular failure. Symptoms: chest pain, dyspnea, shortness of breath. Hypoxemia, pulmonary edema, rales, pink frothy sputum. Hypotension with a narrow pulse pressure, tachycardia. Peripheral cyanosis, cold and clammy skin. Signs of venous congestion: jugular venous distension, peripheral edema. Oliguria or anuria indicating kidney hypoperfusion. Altered mental status, confusion, agitation, or lethargy due to cerebral hypoperfusion. Weak or absent peripheral pulses. Diagnostics: ECG, ST elevation, arrhythmias. Echocardiography, assess ejection fraction, wall motion abnormalities, and valve function. Chest X-ray, signs of pulmonary edema. Blood tests, cardiac biomarkers. Troponins, brain natriuretic peptide BNP. Lactate indicating hypoperfusion. Creatinine indicates renal dysfunction. Hemodynamic monitoring, e.g. pulmonary artery catheter, to measure pulmonary capillary wedge pressure and cardiac output. Management: 1. Acute stabilization. Oxygen therapy or mechanical ventilation for respiratory distress. Inotropes, dobutamine, enhance cardiac contractility, and vasopressors, norepinephrine, maintain blood pressure. Diuretics for pulmonary congestion and volume overload. 2. Definitive management. Revascularization for ischemic causes, e.g. angioplasty, percutaneous coronary intervention, bypass surgery, coronary artery bypass grafting. Mechanical support. Intra-aortic balloon pump, IABP, reduces afterload and improves coronary perfusion and extracorporeal membrane oxygenation, ECMO, for severe cases. Prognosis. Despite advances in treatment, mortality rates remain high, 40–50%. Prognosis depends on promptness of intervention, severity of underlying cardiac dysfunction, presence of comorbidities. Prevention: early recognition and treatment of acute myocardial infarction. Aggressive management of cardiovascular risk factors, e.g. hypertension, diabetes, hyperlipidemia. Timely treatment of structural cardiac abnormalities. Thanks for watching Doc AT.